Yeah, it's a pleasure for me to be here. This is my second time interacting with the community of newborn screening. My first engagement was 2016, I think, in The Hague. And I was shocked to get to know of this great community and to get to know how countries are far advanced in this newborn screening arena, and yet Africa is lagging grossly behind. And I'm happy that I've been given the opportunity to come and share a bit of the initiative that I spearheaded in Uganda to start some level of newborn screening for sickle cell, just as a way to give us a bit of insight of what can we do. We cannot afford to leave Africa behind and advance as the rest of the other continents, and this whole block is left behind because the world is a global village. Okay, so as they told you, and as I've told you, this arena of newborn screening and this community is relatively new to me. I'm very known within the HIV arena, and I've spearheaded loads of HIV programming that has been transformatory. But in this effort, as I was doing HIV work, I spearheaded the newborn screening for HIV in Uganda, and we are receiving all these samples from across the country for exposed infants. Then I got this intuition and I said, can't we do more with these samples that are coming? Can't we get to know, because I knew about sickle cell and how it is really a problem. Then I started having this interest. Then I got in touch with a research group and I sold the idea to them, and they were willing to support me to have some laboratory infrastructure to see that we can do sickle cell screening, just to understand the burden of sickle cell across the country. And later I was meant to understand about PerkinElmer, because that's the technology that we used. And then I came to know that they actually supported us even during that survey. And I want to thank the team, and for having brought me here, I'm quite grateful. So, this program started 2016 when I spearheaded it. Of course, it started at the time in the public sector. Nobody believed in a public system. Even the donors would want to support vertical programming within research centers, within, academia. Public sector was left behind. So we started this newborn screening for EID, for HIV, 2006, using partner labs, 80 of them. And I was spearheading all this work, but it was really a nightmare, and the cost to do this was very huge. The research labs were really not focused on patient care. It was a nightmare getting results out of these labs. Then I started a discussion to convince the donors to say, can't you build something within a public sector so that we can offer these services in a more cost-effective way? It was hard to convince, but eventually they gave me a benefit of doubt, and I set up a centralized lab within the city, and then I had to think about how do samples move from all across the country to get to this lab. Then I set up this system, the sample transport system. So this sample transport system actually is comprised of sub-district networks in form of hubs. So we'd go to the sub-district level, get a health facility which is accessible, and it becomes a hub for that catchment. And then we map it and we locate within a radius of 30 to 40 kilometers. We locate the number of facilities in there, the road network, and create a schedule where these sites can be reached. And then the samples would provide a rider put routes through this network, bringing samples from these lower facilities to a hub. And then we use the courier to move the samples from the hub to the central lab. That was a system really set up to support HIV, early infant diagnosis. But eventually it has been quite revolutionary that even the donors bought into it because it was an infrastructure that would support so many other services. So the hubs that I started with, that I piloted, were 19. Then eventually they were scaled up to 100. The 100 covered, this is the map of Uganda. So all these dots you see are hubs. And the donors eventually bought into it. These are basically USG, PEPFAR donors, but all of them are actually supporting all these hubs, 100 of them. And it was eventually agreed, let the hubs be turned into labs. So kind of creating some bit of decentralization of services, and these hubs are able to provide the routine testing of all the monitoring tests beyond even HIV that the patients will need. And just functionalizing the movement of samples from the lower sites, each hub supporting between 25 and 30 facilities. You have a functional lab at each one of these. You have really solved the problems for most of the facilities. And this actually provides that kind of framework for over 90% of facilities in country. So using this infrastructure and with the support of Cincinnati Children's Hospital, who helped us to get the laboratory infrastructure and training, and of course with support, I understand they got support from PerkinElmer to provide the reagents and so on. We are able to do a survey. Within 1 year, we collected close to 100,000 samples. And these samples actually represent babies, HIV-exposed babies. And we found the burden sickle cell trait on average is about 13.3 nationwide. And of course, disease around 0.7. But of course, it was not uniformly distributed. Some districts were highly burdened. So this is the map of the burden of sickle cell. The darker it is, the higher is the prevalence. So these very dark ones have got prevalence of above 20%. Then these ones are within about 18 to 20, and then the rest of the country, apart from this area where the region, this particular part of the country has very low prevalence. So we actually found that 49 of the 112 districts have a prevalence above 15 of trait. 8 districts have a prevalence above 20, and 14 of the districts actually bear close to 50% of the national burden. And then this would be really a focus for a newborn screening, targeted newborn screening. So having finished the survey, I had to talk to our partners to say, no, we cannot, it's not ethical for us to just paint all this picture and we'll pack our bags and go, because we are research oriented. We must do something at least to keep the flag up until when we will get hands coming in to support us. So they were willing to continue with a level of support that enabled us to continue newborn screening. So the newborn screening, which we have done for 2 years now, is covering these hotspots, these high burden districts that you see. We did it in terms of, we scaled it up. We started with two hubs, and then we increased up to where we are within about 18 hubs. And of course, each hub covering about 20 facilities. That gives you a rough idea of how many facilities we are working in. So, where would we begin? Of course, we begin with the high burden districts. Those are 14 or so districts with a high volume of patients and burden of the problem. And this is the mid-north and central region, and we'll focus on the maternity units and immunization centers, because we were aiming at getting the newborns and then children under 2 years whom we could catch through the immunization program. So using this simple infrastructure of sample transport and using the dry blood spots, we were able actually to reach the remotest of parts of the country. This is one of the very remote parts of the country, but there you could actually access the high level of services. This is the lab actually, where we are doing newborn screening. But people living in homesteads like this would access world-class standard of service by using, a simple framework of sample transport system, and then services are offered. So how did we structure this? By training the sites. We could go and since we are working through these hubs that I've talked about already, we could go out, we could go out and call the lab people, the clinicians, the midwives, and so on, and call them in a training for 1 day, tell them about newborn screening, the burden of sickle cell, how to collect the samples, give them the sample collection materials, and get them to start. And then they start sending samples. And then the lab we have with capacity to do actually quite a number of tests, but we've been limited because of resources. We have about 10 gel boxes. We could do actually we could do over 1,000 samples in a day, but we've been doing about 2,000 in a week. And we've been supported through Cincinnati with a quality bit, like they scan through the gels after our teams read them. They also, do online support to support the quality bit of the service. And we have continued to actually, the capacity was increased after the study, after the survey, and then we do this in the high burden districts, and where it becomes problematic, we do genetic diagnostic just to get some of the hard cases for us to disaggregate. This is part of the lab that is supported and is doing this. So for the period of 2 years where we've been doing newborn screening, we've done like 94,000 tests. Actually, 65,000 of these have come still through the EID program, and about 28,000 have come directly for newborn screening. So what we wanted basically is to confirm, because first of all, when we did the study, the survey, people believed it was biased because we are doing it among exposed infants. And we wanted to see whether the results would differ from if we did it among babies who are not HIV exposed. And we wanted also to confirm HIV comorbidity, because it is one other thing that we saw, that babies who are HIV positive, if they have sickle cell, they are more vulnerable. Their survival rates are lower. So that's what we wanted to prove. The results actually show that there is no big difference between exposed infants and non-exposed in terms of prevalence of sickle cell. So, but what we find, of course, these are the results of our survey. We found that HIV positive infants who are also sickle cell positive. Okay? These are HIV positive and sickle cell positive. There were 23 in that survey that we did, and they had a 40% chance, increased chance of morbidity as compared to those who are non-HIV positive. But in the survey, in the newborn screening, we found we got 54 that are HIV positive and sickle cell positive, and they have a 45% chance of increased morbidity just because of that co-infection. So what have we achieved so far? We have been working so hard to actually set up a framework within which these services can be offered. We have already developed a policy and guideline, and it is being approved through it's at the highest level of approval. We hope to have everything approved this year. We have been doing massive campaigns, sensitization, because the biggest problem is the burden is big, but people are not aware. People are associating this disease they have lots of myths. They think it is witchcraft. They think it is curses. It is all sorts of, weird beliefs. But we want to change that thinking. We've been engaging cultural leaders. We have a very famous king in the country, and on his birthday, he usually advocates for a health need. And I engaged the institution and asked them to actually have sickle cell as the king's birthday activities for the next 3 years. We have done it last year and this year, and usually during the king's birthday there is a marathon, there is a run, and there is a media frenzy. There is all the corporate companies come in because it's very popular. So this is part of the run. So this snap I've given you here is part of the run, but all the focus is on sickle cell. And this year's run was in April, over 60,000 runners, 60,000. But all of it is around sickle cell. And the previous year it was 30,000, but this year we worked so hard and 60,000 runners. So almost information about sickle cell is becoming household. People are getting to know sickle cell, that this is a genetic problem. It's not out of these myths and so on. So we have engaged religious leaders. We are advocating for premarital testing and counseling. We have engaged politicians. We have actually had a statement read on the floor of Parliament to see that government comes in. We are continuing there are some traditional healers who were claiming to heal sickle cell. We have had to engage them and train them, and they have also believed that they are actually telling lies. They cannot heal sickle cell. So we are trying to change the thinking. But what are the challenges? The challenges, we are continuing to drum, but resources are our biggest challenge. And lack of resources, we have actually been told lately to scale down because of limited resources, and we have reduced our testing to less than a third of what we've been doing. And this because of the limited resources. But we have done a lot of sensitization. You go to facilities and parents are brought their babies to be tested, and they are told we are not going to test them. We are not going to collect samples from them. That is quite disheartening, and for us to be able to break through, we need to have some level of service, so that we continue using the data, we continue to advocate until we raise the attention of the powers that be and all the people that need to brought to attention, so that something is done around sickle cell. But if we reduce our efforts, everything will go down. And it's our humble prayer that this effort doesn't go down. So there are opportunities. The opportunities are, if we can actually pin down this comorbidity issue and advocate more, we can get sickle cell tapping into HIV resources. We find there are lots of resources pumped into HIV. Like I told you, the early infant diagnosis program that I support, that I head, is actually targeting just three to 4,000 babies that are born with HIV. But we have 20 to 25,000 born with sickle cell. And by 5 years, 80% of them are dead. So you save 4,000 of HIV and you lose 25,000 or 20,000 of sickle cell. Are you really making any headway? So that is the case that we really have to make. We only can prove this by data. We really need to follow these babies eventually and pin it down efficiently so that we can cause even the HIV folks to understand that sickle cell is not something we should close our eyes on. We should bring it on board. Then, because of course the revolutionary work that I've done around HIV programming and laboratory systems, I was recently given to manage a project that supports the entire continent of Africa to improve laboratory services. It's called the Laboratory System Strengthening Community of Practice. And we hold monthly video calls. It's a big community and quite active, but I visit the countries to help them improve their laboratory systems, set up functional systems, and I'm advocating for sickle cell. I actually tell them about the Ugandan story, how we used HIV infrastructure to map the burden of sickle cell, and they can do the same in their country. So this is an opportunity we can tap in to pull the continent, get it out of the darkness of newborn screening so that they see the light, okay? So they are also, if we can have data, we can compel donors to come along and support this effort and potential to ride on already existing infrastructure and systems like what I did for newborn screening. And this can be just, a precursor for other newborn screening efforts across the continent. So way forward, we should not be scaling down. We should be scaling up services. But because of limited resources, actually, we got information and we have cut down the numbers by we are doing now less than a third of what we've been doing because of limited resources. We need more reagents, laboratory capacity to continue the testing. We need to continue the public awareness, the efforts around premarital testing and counseling. Universal screening eventually comes along, and newborn screening can be, a stepping stone for other newborn screening efforts. So thank you very much. So these are the take-home messages that sickle cell is a major problem on the continent and needs attention. Newborn screening is possible even in a resource-limited setting, especially when you ride it again upon existing systems. We need to ride on these existing systems to build capacity for sickle cell. Public awareness and mobilization of stakeholders, cultural leaders, political leaders, to reduce the incidence of sickle cell, and there is need to have a country success story. Like to penetrate Africa, I think we need to have a success story that we can use to advocate. And we say, this has worked, it can work elsewhere. If it has worked here, it can work elsewhere. And then we bring that continent on board. We cannot be in our club here in silos and we leave them behind because the world is a village now. Thank you.